Thanks to the audience who follows our broadcast. We have the honor today of having Dr. Tanikawa. Dr. Tanikawa is a well-known neurosurgeon at Sapporo Hospital. He is the Executive Vice President and Director of the Stroke and Cerebrovascular Surgery Center at Sapporo Hospital in Japan. Right now, at the 2021 IWBNC, Dr. Tanikawa is going to share a lecture on microsurgery with precise anatomy for cerebrovascular and skill-based lesions. Please type write your question in the Q&A panel. We will read it after the end of Dr. Tanikawa's intervention. Welcome, Dr. Tanikawa, and thank you. It's all yours.
Okay. Can you hear me?
Yes, sir, I can hear you.
Okay. Thank you for your invitation for the International Web-Based Neurosurgery Conference. Congratulations for such a wonderful online meeting. It is very convenient to share our experiences in neurosurgery very instantly on the internet. Today, my topic is precise anatomy and several micro surgical approaches and vascular. I think about the principles of microanastomosis, microsurgery. The most important point is hemostasis, complete hemostasis, to get the brother's operative field. Like before opening dura, the complete hemostasis must be done like this. There are no red cell on the dura mater. And after opening dura, in this case, I am dissecting the left side, the cerebral fissure, and exposing the unruptured choroidal aneurysm like this. During elevation of skin flap and the temporal muscles, as well, the complete hemostasis must be done, and the epidural space, using the appropriate materials to get the hemostasis, like a Sagicel, cauterizing the breathing point of dura, everything. In every step, we have to complete the hemostasis. And in the right lower video, you can see the dural stitching. Basically, I let my young colleagues to close the dura using a microscope like this. Under microscope, the dura is stitched with the 5-0 proline or pronova to get a watertight closure. After closing, almost closing the dura, then we inject the saline in the subdural space and check the water tightness. Because the CSF leakage, CSF collection in epidural space or subcutaneous space, it is a main cause of the post-operative infection, meningitis, or epidural, subdural, NPM or something. So the CSF stopping, CSF watertight dural closure is, and the principle of stitching dura and stitching microvessels is similar. But in the microanastomosis, the most important thing is everything of the vessel wall, like left lower image. Each intima of a donor and the recipient should be attached to each other. Then you can penetrate the micro needle like this. The everything of both vessels principle. And one more important principle is a basic dimension of a microanastomosis to achieve the appropriate condition of the donor and recipient orifice. I recommend the fish mouth trimming like this. That if you cut the donor end with a 60-degree oblique cut, then the same length cutting up toward the proximal side, then we can get this triangle with a 60-degree, 30-degree right angle right here. So this diameter, this length is calculated by 2 times of large D. Large D is a shrunk diameter of the donor vessel. It's calculated with this. So this length is 2 times of shrunk diameter divided by √3, and the total stitching length is twice of this length. So approximately this length is 2.3 times of a shrunk diameter, large D. With this fish mouth trimming, we can get the wider orifice after the microanastomosis. With this fish mouth trimming, we can have the triangular donor flap on the recipient orifice, diverting condition of both donor and the recipient. The intima can be faced each other like this. Then we can penetrate both vessel wall easily. If we stitch the vessel wall, the stitching bite should be twice of the wall thickness, like this. And the stitching interval should be 4 times of the wall thickness. With this principle to stitch, that we have no leakage in between the intervals of stitching after opening the recipient. If we perform the fish mouth trimming with a 60-degree oblique cut, we can have the rhomboid. This rhomboid cross-sectional area can be calculated with this formula. So we can compare it with the right angle T connection. If the T connection orifice can be if it is calculated as S dash, the S dash is simply a pi r square divided by 4. So the ratio between the cross-sectional area of fish mouth trimming, 60-degree oblique cut, and the right angle S dash, the cross-sectional area of this rhomboid is 3.6 times larger than a T connection, simple the perpendicular anastomosis. This is very important. And if we open the vessels with the expanding with the arterial pressure, the rhomboid is expanded like this, like an oval shape, and this means the orifice can be much more larger, more than 3.6 times over T connection. So the Fishman streaming has a very good advantage to achieve the good patency for long-term patency. Again, this is the illustration drawn by my young colleague Cosmonoda. With the Fishman streaming, the triangular depressed in a recipient inside like this, then you can penetrate the micro needle with one action if you achieve the everting condition like this. With the counter force, the left side, I'm right-handed, so left-sided the microforceps, if you put this to the recipient like this, and right side, the forceps can hold the needle and penetrate the vessel wall with one action. It's easy with Fishman streaming. This is a principle. And one more thing, we have to realize that the patient who requires something microanastomosis, regardless the ischemic disease or complex aneurysms, these patients always have the atherosclerotic change of the not only intracranial vessels, but also the superficial temporal artery or radial artery or saphenous. Each vessel, even veins, have the sclerotic change, and this causes easily dissection like this from the outside to inside. The needle tip easily dissect the intima like this. So this is if you could not penetrate the whole layer with the penetrating intima layer, it causes acute occlusion of the microanastomosis. So to avoid it, you have to change the penetrating direction from inside to outside. Then you can prevent the arterial dissection. This is a principle when we perform the microanastomosis. Again, this is a principle to stitch the microvessels. The stitching bite should be twice of wall thickness. The interval should be 4 times of wall thickness. And this means that 2 times of the stitch bite. This is an example of before the Fishman streaming with 60 oblique cut. And before clamping the recipient, you have to finish all the preparation, including the stay suture placement on the heel and the toe. And then you should mark the arteriotomy line on the recipient with the crystal violet. And then with the highest magnification, you can make the straight incision on the recipient. And then I usually stitch the heel side stay suture first. And this is the 10-0 suture. And then you can stitch it 3 times, tying 3 times. Toe side. Again, highest magnification, then penetrate the recipient wall. Now, we can start the stitching. Before stitching one side, first side, the triangular flap of a donor should be placed inside of a lumen. This is the intermediate stitch suture in the upper side of our anastomosis in our operative field. So this is the first stitch next to stay heel suture. Here is the most difficult point to stitch. And once you finish the one size sutures, you have to confirm the inside whether there is a mouth stitching, reverse stitching or not. And then if everything was good, you can start the other side stitching with the intermediate stay, and then the stitching can be started from heel side, and then it is coming back from the toe side to the intermediate stay suture. After the finishing, and check the leakage and patency of the anastomosis. Next, I'll show you a microsurgical approaches, especially for posterior fossa. The posterior fossa lesions, regardless aneurysms or skull with tumors, the a bit complex. For example, if we perform the clipping for distal basilar aneurysm, basilar top, or basilar supracerebellar aneurysms, or high position anterior inferior cerebellar artery aneurysm, basilar trunk aneurysms, the anterotemporal approach is useful to approach such aneurysms. But the subdural anterotemporal approach using a distal transribbian approach is limited if the veins is complex and the veins could not be separated completely from in between the temporal and the frontal lobe. Sometimes the epidural anterotemporal approach is useful, like so-called the epidural anterotemporal approach, or epidural temporal polar epidural approach, something. Anyway, in this case, the dura propria can be elevated from a cavernous lateral wall, and you can expose the cavernous segment of oculomotor nerve, fourth nerve, and the V1, V2. That sometimes expose the V3. And we have to run the precise skull with anatomy like this. And if you go to a middle fossa, we have to confirm all the anatomy, foramen rotundum, ovale, and foramen spinosum, the geniculate ganglion, the greater superficial petrosal nerve, and the temporal rhomboid, and the identification of such the anatomical landmark in middle fossa is very important. And if you go to a basilar trunk or lower basilar arteries, the posterior petrosectomy is useful. To do this, we need to run a mastectomy. We can achieve the operative field after the mastectomy and opening a pre-sigmoid dura. You can achieve the operative field in between the 7th nerve and 9th nerve. The very tiny space, but this is useful to approach the basilar trunk. And if we approach to vertebral artery aneurysms or vertebral artery union or lower basilar trunk, the transcondylar fossa approach is useful. To do this, we need to understand the condylar fossa anatomy, condylar fossa dissection, and the during, the bony during, especially confirming the posterior condylar emissary veins and canals. Because the posterior condylar emissary vein always crossing the craniovertebral junction between the occipital condyle and vertebral venous plexus. After the manipulating and appropriate management of a posterior condylar emissary vein, then you can explore the true condylar fossa. And by the during of condylar fossa, you can explore the hypoglossal canal, and you can drill the posterior half of a jugular tubercle under the sigmoid sinus here. This is an example of a transcavernous approach. By elevating dura propria from a cavernous lateral wall along the tentorial edge, without anticrinoidectomy, you can expose the operative field like this. This image again is being drawn by my colleague Cosmonoda. If we magnify the operative field like this, you can see the third nerve in cavernous segment can be seen like this. And in this picture, the oculomotor foramen is here. It can be released, opened, and then you can mobilize the oculomotor nerve in a very long segment. If necessary, we can dissect the first nerve in the cavernous sinus, and we can open the porus trochlearis. And then by mobilizing a first nerve from the border of a V1 segment, that we can expand the Parkinson triangle if necessary to approach to a lower basilar or mid basilar. This is the anatomical landmark that everybody knows. Here is the crinoid of anterocrinoid, apex of anterocrinoid, oculomotor foramen, third nerve cavernous segment, third nerve cisterna segment, under the P2A, and here is the PCOM, the P1 segment right here. And in between the first nerve and the V1, there is a Parkinson triangle. Here is the superior triangle. And in between V1 and the V2 at the foramen rotundum, there is the anterolateral triangle. And lateral to a V2 segment, there is a far lateral triangle or lateral loop here in between the V2 and the V3. So here, this segment is the supraorbital fissure, and then here is the foramen rotundum. I'll show you an actual example of the basilar top aneurysm unruptured one, the relatively small unruptured aneurysm. In this case, right side front temporal craniotomy is performed, and epidural dissection of a cavernous sinus by the peeling out the dura propria from a cavernous lateral wall. Here, gradually the cavernous lateral wall is exposed, and my crick is trying to approach to the basal trunk. In this case, because of the atherosclerotic change, the carotid is laid down laterally, so the retrocarotid space was very narrow like this. If we put the temporal clip on the basal trunk, the retrocarotid space is very small, and the head of a temporal clip is interferes everything, and the clip applier, the attaching to oculomotor nerve, it may injure the oculomotor nerve. So I extended the epidural space dissection and opened the oculomotor foramen, and I expanded the infraoculomotor space and the supraoculomotor space. Then, under the oculomotor nerve, you can place the temporal clip on the basal trunk. In the supraoculomotor triangle, you can dissect the aneurysm. Here, this is the aneurysm. And I'm confirming the important perforators behind the aneurysm in the supraapicum triangle. Infraapicum triangle, supraoculomotor triangle can be used as the corridor of clip applying. Then, after placement of a neck clipping, you can remove the temporal clip. And this is a CT angio immediately after surgery. Everything was good, complete overrotation aneurysm. And this is the picture what we did, drawn by my colleague Cosmo. You can see before the elevating dura propria, before opening oculomotor foramen, the retrocarotid space was narrow, but by opening the oculomotor foramen and remove the tentorial edge, you can expand the retrocarotid space, especially infraoculomotor triangle. And the infraoculomotor triangle expansion can be a space to secure the proximal basal trunk. This is a very important anatomy. This is an example of a basal trunk giant aneurysm. This is one of the most difficult aneurysm to treat. And how do you approach to this aneurysm? This is very complex. Usually, I try to perform the combined petrosal approach. The meaning of a combined petrosal approach is combined approach with anterior petrosectomy and posterior petrosectomy. So to perform the anterior petrosectomy, you have to go to a middle fossa to drill away the temporal rhomboid bone. And we have to understand the precise anatomy, the V2, V3, the V3 posterior border, and the GSPN, geniculate ganglion, arcade eminence, petrous edge. This black rhomboid is so-called temporal rhomboid. And this lateral blue triangle is so-called Glasscock's triangle. The definition of a Glasscock triangle is a posterior border of foramen ovale, crossing point of GSPN and the V3 posterior border, and cochlea. And this is a Kawase triangle, medial to a GSPN, posterior to a V3 posterior border. The definition of a Kawase triangle is a crossing point between the GSPN and the V3 posterior border. And posterior point of pores trigeminus and cochlea. This is a definition of a Kawase triangle. And if you try to draw the temporal rhomboid, you can start the drawing from the anteromedial corner of the temporal rhomboid along the petrous edge, because here is the safest part in this temporal rhomboid, because under the GSPN, there is the C6 internal carotid under the GSPN. So if you drill close to a GSPN, if you drill the temporal rhomboid bone close to a GSPN, you may injure the C6 internal carotid. So we have to be careful. And again, we have to understand the direction of internal auditory meatus from the crossing point of GSPN line and arcade eminence. Here is geniculate ganglion. And with a 60-degree dividing, this direction is internal auditory meatus. Then, after during the temporal rhomboid, anterior to internal auditory meatus, along the C6 internal carotid, along GSPN, you can drill away the temporal bone, and you can skeletonize the cochlea like this. And posterior to internal auditory meatus, between IAC and the suprasemicircular canal, you can drill here this space, posterior meatal space like this. You can expand the temporal rhomboidectomy like this. And in this anatomy, in internal auditory meatus, there is the facial nerve, the cochlear nerve, and the vestibular, the superior and inferior vestibular nerve right here. And the cochlear nerve is running under facial nerve toward the cochlear. And you can see the vestibular nerve is coming into a vestibule, and the facial nerve is running bit curving anteriorly toward the geniculate ganglion, then the geniculate ganglion dividing the greater superficial petrosal nerve, and then the facial nerve trunk is turned posteriorly the tympanic segment. Then it's coming down toward the fallopian canal. This is the important anatomy. This is a example of the anteropetrosectomy. Now, the temporal rhomboid is exposed, and the V1, V2, V3 is confirmed. Now, I am opening the porus trigeminus. You can see the trigeminal, the cisterna root, and this is anterior to the porus trigeminus. I'm opening the space in between V1 and the first nerve. There is a Gruber's ligament right there. And anterior to the V3, V2 fibers, there is a meningioma here. So the compressed, the V2, V3 fiber is placed under the tumor. And by the removing the tumor in a gastrin ganglion, you can expose the sixth nerve, which is coming up in inferior petrosal sinus as a Duro's canal. Everybody knows sixth nerve is running medial to a V1 in a cavernous segment. Now the inferior petrosal sinus is packed with a gel form, and the tumor attaching to a tentorium, it can be resected. And here the anatomy, that's the trigeminal nerve, and anterior to trunk of trigeminal, there is the motor root of trigeminal, and this is the first nerve. It is coming into porus trochlearis, into the tentorium. this is a final view of the tumor removal. But in this case, as I showed you in the first part of a video like this, here, this is the important anatomy. Here, the V1, V2, V3, foramen ovale, rotundum, posterior border V3. Here is the GSPN. This is a very important anatomy. To perform the posterior petrosectomy, we need to understand the mastoid anatomy. This is a landmark of the mastoidectomy. Here is the asterion, the three bony sutures gathering point, parietal mastoid suture, lambdoid suture, mastoid occipitomastoid suture. Here is the asterion, the mastoid tip, root of zygoma, spine of Henle. This is a so-called outer mastoid triangle. Here is the digastric groove, just posterior to a mastoid posterior border. By drilling here, you can expose the sigmoid sinus, the sigmoid sinus hip, the jugular bulb, temporal tegment, sinodural angle. Here is the suprapetrosal sinus. There is a lateral semicircular canal in the antrum. In the antrum, you can find the incus right here, anterior to the semicircular canal. The lateral semicircular canal is a very important landmark during mastoidectomy because the surface of a lateral semicircular canal is approximately 15 millimeters from the surface of a mastoid bony surface. And fallopian canal, tympanic segment of facial nerve and fallopian canal right here, this segment is in the same depth with the lateral semicircular canal. And the posterior to a lateral semicircular canal, there is a posterior semicircular canal. And here is a super semicircular canal, bit deeper to a lateral semicircular, anterior to a posterior semicircular. There is the anterior limb, posterior limb of a super semicircular canal. And as well, the coda tympani is arising from the lower facial nerve in the fallopian canal toward the tympanic ring, tympanic membrane ring, outer ring. And this is the important anatomy of a mastoidectomy. So in the outer mastoid triangle, you can explore the important anatomy, landmarks in a mastoid. If we perform the mastoidectomy with this skin incision, then you can explore the mastoid after elevating sternocleidomastoid mastoid and occipital mastoid and the partially splenius capitis. Then you can expose the mastoid. And you have to confirm the asterion, spine of Henle, and mastoid emissary vein, the mastoid emissary canal. And this is an outer mastoid triangle. Then you can drill it. Then at first, you can find first the sigmoid sinus, the main part, and the temporal tegment, temporal dura. And then gradually you can drill away the mastoid bone. You can explore the antrum, mastoid antrum. Then you can find incus. Then gradually you can skeletonize the lateral, posterior, and superior semicircular canals and the fallopian canal. Here is the digastric ridge. Then you can skeletonize the jugular bulb, the digastric ridge, the fallopian canal. So in mastoidectomy, if you remove the posterior petrous edge lateral to superior semicircular canal, you can complete the posterior petrosectomy like this. This is the just the mastoidectomy, remaining the bone posterior to a semicircular canal, posterior superior to a superior semicircular canal. Here is the edge of petrosal edge, remaining bone posterior to a semicircular canal. If you drill away this part of bone carefully, you can expose the superior petrosal sinus toward the superior semicircular canal, and then completely you can skeletonize the vestibule like this, semicircular canals. This is the posterior petrosectomy, complete posterior petrosectomy. Then we can perform the combined petrosal approach with the posterior petrosectomy and anterior petrosectomy. As I mentioned, in a posterior petrosectomy, we can obtain the operative field in 7/8 complex and the 9th nerve. Usually I perform the combined petrosal approach with the skin incision, large L or large C incision along the ear, posterior to ear, including the transverse sigmoid sinus, like this. After elevating skin, then the temporal muscle and the suboccipital muscles is elevated. You can perform the mastoidectomy first, then you can make the craniotomy, the suboccipital and supratentorial craniotomy with one piece. Then you can perform the anterior petrosectomy through the temporal rhomboid, like this. This is the operative field after mastoidectomy and anterior petrosectomy. You can skeletonize the trigeminal nerve, GSPN, internal auditory canal, semicircular canals, the facial nerve. This is an example, 59-year-old man, right vertebral artery fusiform aneurysm. In this case, in the previous operation, the left side vertebral artery fusiform aneurysm is trapped. So there is the right side vertebral artery remaining, but the right side, the fusiform dissecting aneurysm is grew up. So this time we have to reconstruct the basilar artery. Instead of the vertebral artery, we have to make the bypass in between extracranial V3 segment and P2 right side with a radial artery graft. This is the radial artery graft. After the combined petrosal approach, anterior and posterior petrosectomy, you can achieve the operative field like this. In between the superior semicircular canal and the temporal lobe, you can get the operative field to stitch the radial artery to P2A. And this is the radial artery placed medial to sigmoid sinus, and the proximal end of a radial artery is anastomosis to extracranial V3 segment, like this. Then the radial artery can be opened, and the icy green shows a good patency of a radial artery graft to a P2 segment. And now we can approach to the right vertebral fusiform aneurysm. This is a proximal vertebral artery proximal to aneurysm, and the proximal occlusion, the clip is placed, and I'm confirming the bypass, and everything is filled completely. I'm confirming the perforators from pica. all the perforators is preserved. So this is the closure of the head. This is the final view of the operation. Now, in this case, the V3P2 radial interposition graft is placed. As well, the STA, SC anastomosis is performed. Anyway, with this bypass, you can see all the basilar artery is filled retrogradely through the bypass, and the distal part of aneurysm is still filling, but this aneurysm can be thrombosed gradually, and the patient recovered well. So I think it's almost time to finish my lecture. I can finish. So to finish my lecture, this is a summary of the lateral skull, anterior skull base. The anterocranial process and cavernous sinus lateral wall anatomy is very important, like this. And we can dissect the super triangle, Parkinson triangle in between fourth nerve and the V1, in between the third nerve and the fourth nerve. Then you can expand the space to secure the mid-basilar or lower basilar. And understanding the exact landmark anatomy of a lateral cavernous sinus, here the superorbital fissure, and inferior to end of a superorbital fissure, there should be a foramen rotundum, there should be a foramen ovale, and posterior to a bilateral triangle. And to approach to a distal basilar aneurysm, the retrocarotid triangle, which is constituted with the carotid, the temporal uncus, and the tentorium. This triangle is a main corridor to approach to a basilar trunk or basilar SC aneurysm. But depends on the patient atherosclerotic change of, especially of internal carotid artery. If the carotid is laid down laterally, the retrocarotid space is narrow. To expand it, we can dissect the tentorium, especially opening the oculomotor foramen, or if necessary, we can dissect the fourth nerve in the cavernous segment and mobilize the fourth nerve toward the third nerve. Then we can expand the Parkinson triangle. This is an important landmark. So the supraoculomotor triangle, supraoculomotor space, and the infraoculomotor space. This is a very important, if necessary, to expand. And middle fossa anatomy, mastoid anatomy, it's a very important that we have to run it. And we have to go to a cadaver dissection to achieve the knowledge of the anatomy. Otherwise, it's impossible to safely and to get the appropriate approach. I have the limited time, so at this time today, I didn't mention the suboccipital muscular dissection, but the suboccipital muscular dissection is very important to harvest occipital artery, especially to harvest occipital artery. I recommend to dissect the layer by layer suboccipital muscular dissection. Okay, that's all. Thank you very much.
Thank you very much for such a wonderful lecture, Dr. Tanikawa. I'm sure all the audience has learned from your experience. Right now, we have a few questions from the public, Dr. Tanikawa. Dr. Gomez asked, what is the maximum time that arterial flow can be clipped when doing a bypass, and is it the same for all vascular territories?
Depends on the patient collateral circulation. For example, when we perform the STMC bypass, in my experience, the less than 30 minutes temporary occlusion of a middle cerebral artery, like a M2 segment or M3 segment, distal to a M2 segment, the less than 30 minutes is safe. But more than 30 minutes, some patients have the ischemic complication. So this is the reason why I always recommend young guys to have a training to do a micro stitch in a short time. The principle is 1 minute for one stitch. So I usually perform the 18 to 20 stitches in end-to-side anastomosis between STA and M2 segment or M3 segment. If you spend 1 minute for one stitch, even you stitch 20 stitches, you can finish the anastomosis in 20 minutes. So in a dry lab training or using animal training, in anything, we should train the microanastomosis 1 minute for one stitch. This is the principle. And but if we occlude the larger vessels like internal carotid or basal trunk, the temporal occlusion time is very limited. In my experience, ICA or basal trunk should be limited less than 10 minutes. The longest time is 10 minutes. So we have to be careful using something, always using a neural monitoring like SSEP or MEP or EEG. We need to check it. So the temporal occlusion time should be shorter.
Okay, Dr. Tanikawa, thank you very much. There is another question. Do you prefer open vascular to an endovascular management in basilar tip aneurysms?
Depends on the discussion of the patient. Everybody knows the recurrence rate is a problem. In general, depends on the endovascular surgeon, but the recurrence rate of the coiling aneurysm is higher than surgical clipping. So we have to indicate our surgical experience, surgical result of the neck clipping of aneurysms. In our experience, the recurrence rate after neck clipping is 0 in this 8 years with almost 2,000 unruptured aneurysm cases. But on the other hand, everybody knows the endovascular coiling, especially bare coiling, has a 20 to 30% of recurrence rate annually. And if the aneurysm is getting larger, the recurrence rate is crossing to 50%. Some has the 60%, 70%. So this is a program. So we always have the discussion with the patient and the patient family. And after the discussion, patient can decide which surgery is appropriate for them. And if patient chose the endovascular, I send the patient to an endovascular surgeon.
Thank you, Dr. Tanikawa. Dr. Humberto is asking, how do you evaluate collateral circulation prior to bypass surgery?
The angiography is very important. If you perform the angiography, we can check the circulation time. And if you perform the balloon test occlusion of the internal carotid, you can check the circulation time. As well, we can check the stump pressure after the internal carotid occlusion. Before and after, we can measure the intra-arterial pressure. Before occlusion internal carotid artery, you can measure the intra-internal carotid artery pressure. And after balloon inflation, you can measure the internal carotid artery pressure as a stump pressure. So we can calculate the stump pressure divided by control internal carotid artery pressure. This ratio is very important when we perform the therapeutic internal carotid occlusion. As we have published the formula according formula to calculate the expected middle cerebral artery pressure after the therapeutic carotid occlusion with high flow bypass between external carotid and middle cerebral artery on Journal of Neurosurgery in 2016. You can find it. The formula is very simple. The quadratic function of formula, we can easily calculate the appropriate size of a high flow graft. Anyway, we can evaluate the collateral circulation on the angiography mainly, but simultaneously we can check the single photon emission tomography. If it is difficult or it is impossible to check the single photon emission tomography, depend on the institution, you can use the CT perfusion or MRI perfusion instead of a single photon emission tomography, especially using mean transition time or cerebral volumes. These parameters can be a good factor to evaluate CBF before surgery.
Thank you, Dr. Tanikawa. And the last question, Dr. Beltran is asking, what kind of consideration do you have when you operate a pica aneurysm?
Considerations? You mean the surgical procedures?
I think yes.
If we approach to pica aneurysm, for example, vertebral artery pica bifurcation aneurysm, if the aneurysm is not so big, if it is feasible to clip, we can use the simple suboccipital craniotomy. But in case of something happen, for example, the pica occlusion after neck clipping, pica occlusion happened because of atherosclerotic change or something, that we need to reconstruct the pica. In case of such a condition, I always prepare the occipital artery. During craniotomy, as I mentioned, I couldn't show you a suboccipital muscular dissection today, but during suboccipital muscular dissection, I always harvest occipital artery before craniotomy. And in case of such something complications, immediately I can perform the occipital pica end to side anastomosis distal to the aneurysm. But if you couldn't preserve the occipital artery, you can perform the pica side-to-side anastomosis. But we have to be careful. Regardless, pica, the side-to-side anastomosis is dangerous because if you fail the side-to-side anastomosis, you lose two vessels, both vessels. So the side-to-side anastomosis cannot be your first option. I always recommend the occipital pica end-to-side anastomosis first. Even if you fail, you have a trouble in occipital pica anastomosis, you can again try the end-to-side anastomosis with pica and occipital artery. So I always recommend my young guys to harvest occipital artery when we approach to a pica aneurysm. Even the pica was feasible to be clipped. This is my concept.
Thank you very much, Dr. Tanikawa. On behalf of CN, I would like to thank you again, Dr. Tanikawa. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2021 IWBNC.
Thank you. Thank you very much.
Thank you, Dr. Tanikawa.
Okay.
For all the audience, keep in mind this lecture will be able on our website starting next week. Thanks to all the audience for accompanying us during this very second day of the 2021 IWBNC. We hope you will be able to connect to our broadcast tomorrow morning at 8 a.m. EDT. Don't forget to check the full program schedule on our website. Thank you very much and have a good night.
Thank you. Bye-bye.
Thank you. Bye-bye.